Hi, everyone. This is Matt Fox from Free Associations, and I want to welcome you to a very special bonus episode of the podcast from Boston University School of Public Health, in which we have our first author response segment. So you'll remember back in episode 14, we talked about a study from the New England Journal of Medicine, which was called HIV Prevention Efforts and Incidence of HIV in Uganda, and it was led by Dr. Kate Grabowski from Johns Hopkins. And this was a study on the dropping incidence of HIV in Uganda and what it is that might explain it. And after the episode came out, Kate had a chance to listen to the podcast and correct us on a few issues that came up, and that all happened on Twitter, and we thought it would be a good idea to actually get her onto the podcast so we could make sure that everyone had the record straight on a few issues that we definitely got wrong in the podcast version. So Kate, welcome to Free Associations, and thanks for agreeing to come on and talk about your study, and thanks for being our first ever guest.
Wow, this is quite an honor. Thanks for having me, Matt. I loved your podcast.
Thank you very much. So before we get into the details, can you just give us a bit of background on you in terms of your training and how it is that you got into working on HIV incidence in Uganda?
Yeah, sure.
And we should say both Kate and I are work at hospitals, and so you can hear an ambulance in the background there.
Yeah, it's a very regular occurrence on Monument Street in Baltimore, so apologies.
No problem.
So I actually did a study abroad program during my undergraduate degree, and I was in Cape Town in 2003. And that's when I first started getting interested in HIV and in epidemiology. And after I finished my undergrad degree, I went to Hopkins for a master's in epidemiology, and I started working on the multi-centered AIDS cohort study and the AIDS linked to intravenous experience study, which are commonly referred to as the MAX and the ALIVE cohorts. Mm-hmm. And so I really started getting interested in longitudinal studies and HIV research, and so I wanted to get more experience with that after I graduated. So I went and worked for 2 years with the Rwanda-Zambia HIV research group in Rwanda and Zambia on discordant couples cohorts. And discordant
couples meaning one partner is positive and one is negative.
One partner is positive and one is negative. And this was just really as ART was being rolled out. We were only treating people in the late stages of infection. So we were still following these couples over time to see who got infected. Now you can't do that because everybody who we identify as HIV positive goes right on to therapy. So those were the studies I was working on at the time. And I spent 2 years doing that, and it was awesome. I had a great time, and I became even more interested in doing HIV research. So when I came back to do my PhD at Hopkins in 2009, I was looking to work with a group who was doing research in Uganda. And I had been assigned to tutor someone in my PhD cohort who happened to be working with a Ugandan project. And he linked me up with Ron Gray and Maria Wayward, who are the co-founders of the Chi Health Sciences program. And I have been working with them ever since. So that's how I got started.
Fantastic. And I should correct something. I think I said on the actual podcast episode that that the Rakai program had been going on since the early 2000s, but I think it may have even been longer than that. Do I have that right?
Yeah, it's much longer than that.
Yeah, so the 90s, right?
Yeah, so actually they had done their first population-based serosurvey in the Rakai district in 1989.
Oh, wow.
And then, and what they found was like really astronomically high HIV prevalence. 30% of the population was infected. It was a public health emergency in their eyes. So they decided to see what they could do research and programmatic wise. And the big hot topic at the time was STI, or control of sexually transmitted infections, to reduce HIV infection. Right. So they thought if you could reduce genital ulcers and gonorrhea and syphilis, then maybe you could prevent HIV acquisition. So they started this community randomized controlled trial. And that community randomized controlled trial, once it ended, those communities continued to be followed. And that's what the Rakai community cohort study is today.
Yeah, it's really an amazing body of work that's come out of that population over, as you say, almost 20, 30 odd years.
Yeah, it's a really long time.
And I should say, I taught a course for almost probably, I don't know, 8 years or so that was entirely based on the study that you just described, the one on STIs and increased risk of HIV transmission, comparing that study in Rakai to the Mwanza one in Tanzania, which looked at the same thing, and they found different things, and it's just a fascinating case study. So let's transition into your study. So my hope is that everyone who's listening to this has listened to episode 14 and knows exactly the details of the study, but I'm guessing there might be one or two people out there who haven't. So can you give us the short version of what the study is, why you did it, and what you found?
Yeah, so we were interested in assessing the population effectiveness of various HIV prevention interventions that have been scaled up largely through the President's Emergency Plan for AIDS Relief, or PEPFAR. And to do that, we used data collected through the Rakai community cohort study. And we focused on communities that were continuously surveyed between 1999 and 2016. So we've surveyed anywhere from 45 to 50 communities over the years, but these communities were continuously surveyed over that period, and data collection on key confounders and sexual behavior variables were uniformly collected over that period. And so in 2004 was when ARVs became available. And shortly after that, the male circumcision trials had concluded. And PEPFAR was rolling out both ART and medical male circumcision for HIV prevention. Over this same time period, there was behavioral interventions that were ongoing, including things like condom promotion and couples voluntary testing and counseling, and a whole host of other activities. So we wanted to know if these programs that had really began being scaled up in earnest in 2004, if they had an impact on HIV incidence in our whole population. And so what we wanted to do was to look at what the incidence rates over time were in these 30 continuously surveyed communities between 1999 and 2016. And we also wanted to look and see whether or not the individual level risk of HIV infection had changed as well. And so basically we assessed HIV incidence prior to 2004, which we consider the baseline period. I think that was really well described in your podcast.
And it's just worth noting that the prior to 2004 is the period before the large-scale rollout of ART or HIV treatment.
Yeah, exactly. And so that was our baseline period. So there weren't, about 15% of the male population were circumcised, and those were predominantly Muslims. And no one was on ART during that period. It was a really terrible time. There was a very high mortality. And then in 2004, ART became available, and it was rolled out according to WHO CD4 initiation criteria. So initially they were only providing ART to the sickest people, but then as of the more recent rounds, those criteria have changed and more people are now eligible. So a lot more people are on ART. And so these interventions sort of gradually scaled up between 2004 and 2016. And what we saw were a few different things. So first we looked at whether or not sexual behaviors had changed. And the one thing that we noticed was that very young people between the ages of 15 and 19 a lot more of them were delaying sexual debut. And that we think is probably because of mandatory secondary education that was implemented by the Ugandan government also around 2004. Mm-hmm. But unfortunately, we didn't see any changes in condom use with non-marital partners, and we really didn't see any reductions in the total number of sexual partners that people were having on an annual basis. So beyond the delay in sexual debut in the very young, there wasn't much change in sexual behavior. The other major thing that we saw were declines in incidence beginning around 2011 and 2012, once we had about 30-40% ART and male circumcision coverage. And so we started to see declining HIV incidence with increasing coverage of these interventions. And by 2016, we found that there was a 42% reduction in HIV incidence compared to that baseline period prior to ART and male circumcision availability.
A 42% reduction in incidence.
Yeah, overall.
Yep.
But one of the key things that we also found was that this was differential by gender. So unfortunately, reductions were not as great in women. And we think that's probably because men were both benefiting from the direct effects of male circumcision, but also higher ART coverage levels in women. So across sub-Saharan Africa, we see that men are less likely to engage in ART care and treatment services. And it's a problem that we're trying to address with a number of interventions right now.
And this is something that we see all over Africa, as you say. I mean, every report of the demographics from an HIV clinic that I've ever seen, you can reliably predict that it's going to be between 60 and 70% female.
Yeah, it's really striking how consistent that is across study setting in sub-Saharan Africa. We have a grant on that's just finished. It was a qualitative grant where we were doing interviews with men to try to figure out why this was, and the title of that grant was called "The Problem with Men."
Yeah, it's an issue. I mean, it's a really big issue, and it is unfortunate. I mean, I said, it's a pattern of care-seeking behavior that existed long before HIV came along, but it's certainly an issue we need to deal with. So I wanted to ask you, specifically, are you able to tease out whether it's the circumcision or the treatment that is having the bigger effect?
Yeah, I don't think we can do that with these data. So we talked a lot about that. One thing we did do was we looked separately. I mean, we did look separately by circumcised and uncircumcised men and according to gender to try to tease out what the ART effects were. So presumably among uncircumcised men, we're seeing the impact of ART. Because it's unlikely we're going to be seeing the indirect effects on male partners this early after circumcision rollout. Mm-hmm. So that was one sort of shallow attempt to do that. And we have, we have some modeling work that we're considering, as well as some work looking at stable partner networks to try to tease out some of these effects right now. But I think it's really challenging. These interventions were scaled up at exactly the same time. And I think, for a lot of other populations where this is also occurring, it's also going to be kind of challenging to tease out the impact. I do think circumcision is a very, very effective intervention that doesn't get any love, though. And you can see in the figures and in figure 2, I believe, in the paper, that the incidence is really sort of dramatically reduced, particularly among circumcised men. They have incidence rates about 0.3 per 100 person years, which is pretty incredible.
It's really incredible.
Yeah.
And so you just raised the issue of circumcision being a very effective intervention. I think you're aware that when I tweeted out that this episode was coming out, there are people in this world who are very critical of the 3 trials that were originally done on the protective effects of circumcision for men, protective against HIV acquisition. There, as far as I can tell, and I've done extensive reading, their arguments have really almost no merit. They have a few claims that I think are sort of valid claims, but they don't explain away the massive protective effect. But It gets to the issue that I wanted to ask you about this study, which is you just said that you found about a 42% reduction in incidence associated with these two interventions. The original circumcision trials found about a 50 to 60% reduction associated with circumcision alone. So I suppose the first question is, do you think there's a reason why the trials found a 50% reduction with only circumcision, whereas here you've got both interventions and you're finding less of a reduction?
Yeah, I mean, remember this is the real world. So, and
Yep.
and these RCTs where people don't choose to get circumcised, they're either in the intervention or the control arm, and when they sign up for the study, they say, I agree to be in the intervention or the control arm. But in reality, there's self-selection into circumcision services. So what we've seen actually in Rakai is that and this is in the supplement too, if you're interested, for those that are interested, but it's really the very young that are getting circumcised right now, and we have some gaps in the older age groups in circumcision coverage. So it's non-uniform in the population. And because of this, we think that might have attenuated the population level impact in Rakai.
Yeah, and I suppose I would say, I mean, I think the part of the real difference is that in the trial, you're looking at the benefits to the individual, whereas here you're looking at a larger, more population level effect. And as you say, not everyone's getting circumcised, whereas in the trial, it's, you're comparing those who were to those who weren't. And so then I wanted to get... Yep.
I just wanted to say we did actually report on the individual level effect of male circumcision in the study, and it was about it was a 40% reduction, so it was slightly lower than what we saw in the trials.
Which of course is what you'd expect, as you say, under real world conditions, with probably some residual confounding. Mm-hmm. And so the second issue that I wanted to raise was the people who are critical of the original circumcision trials want to make the point that this 42, or in the case of the trial, 60% reduction is something that we really emphasize, when in fact we're talking about a small absolute reduction, that the incidence of HIV, the yearly incidence is about 1.5% there?
Well, now it's down to about, I think, what was the final estimate in our paper, like 0.7 or 0.9 per 100 person years, and it's much lower in men. I mean, this is what we're reporting on the New England Journal of Medicine paper. It's not just an individual level risk reduction. The overall HIV incidence, particularly among circumcised and particularly among men overall, has gone down. It's for men, the incidence has declined by almost 50%. So that is, I mean, I actually responded to this for a PolitiFact podcast, the same argument.
Yep.
And no, we do actually see large reductions in the number of cases because of this.
Right. And I think the issue here is, and I'm a very, very strong believer in the idea that we need to report both relative and absolute differences. Mm-hmm. But I think the point that gets missed here is that if you have a 50% reduction off of a base of, let's say 1.5% per year, roughly. Mm-hmm. I mean, that's a rough translation. That can seem like a small number. 50% reduction then gets you from 1.5, or let's say 1.2 to 0.6 or whatever it is, percent. But we're talking about per year. And so when you start to multiply that out, and then you start to think about, for each person who's not getting infected, they are not then transmitting to 4 or 5 other people. The knock-on effects are huge. And so the idea that you would dismiss a 50% reduction in incidence because it's a small absolute difference on a yearly basis is absurd. And I find the argument so frustrating that I just wanted to clarify that. It's really important.
I'm not sure if you've covered this on your podcast, but I think talking about absolute and relative risk differences, people confuse that all the time. So I think to some extent what they're arguing is that if not a lot of people in your population are circumcised, then circumcision really isn't going to make that big of a difference. Mm-hmm. But now 60% of our population is circumcised. And so we have high coverage of the intervention. And because we have high coverage of the intervention, we do see these reductions in incidence. And an incidence of 1.5 per 100 person years is huge.
It is huge.
It's huge. And that's why we have such a big epidemic in Africa. The prevalence in our communities is 14% of 15 to 49-year-olds. And so I think what's really awesome right now is we're starting to see reductions in male HIV prevalence, even despite the fact that we have ART. So ART increases survival, so you would expect to see higher prevalence once you roll out ART. And right now we're starting to see reductions of HIV incidence even with rollout of ART and the increased survival. So that's super exciting. But yeah, I find that argument to be really frustrating.
And let me just sort of emphasize it once more. I want to repeat what you said, which is 1.5%, per year is huge. That's a huge incidence, because if you think about that over a 10-year period, you're talking about 10 to 15% of your population being infected. And if we can cut that in half, we go from 14 to 7. Now that's going to take a long time, because incidence and prevalence are two different things, and people with HIV thankfully are living, so prevalence isn't actually dropping as quickly. But that kind of a cut in HIV incidence is massive.
Yeah. It's a fantastic intervention. I'm sure I'll get a lot of angry emails.
Well, I'm sure I will as well, but I'm happy to get those. I'm happy to get those, because this is important stuff. Okay, so let's get into the issue that I very clearly got wrong, and the issue of whether or not your study was ecologic, which I should say right up front. You say in the paper this is a cohort study, not an ecologic study. And my confusion on this sort of came about because while it certainly is a cohort study, and I think I did at least note that you were dealing with individual level data, while this is a cohort study, you are dealing with a population level variable that you are trying to relate to individual level incidence. That population level variable being the coverage of circumcision or the coverage of ART HIV treatment. So can you explain why this is not an ecologic study where we correlate to population level variables, but it's actually, in which case it becomes difficult to actually assess causation, to why this is a cohort study in which you can?
Well, so we were following individuals over time in the study. So typically for ecological studies, you have both exposures measured at the aggregate or population level and outcomes measured at the aggregate or population level. So you don't really know within individuals whether or not particular exposures are reducing or increasing risk for some outcome. You can't say that with confidence. You can only correlate these two measures together. And that's typically what I think of as an ecological study. But here, the Rakai Community Cohort Study follows individuals over time. And what we were doing was looking at individual level risk over time. So a person would come in, we would interview them, they'd come back, and we'd interview and test them for HIV again, and we would see if their status changed. And because we had that data on the individual level, it's not an ecological study. So I disagreed with that point.
And you're 100% right. And I did try to put it into the introduction when I realized I'd gotten that wrong. But it obviously is not as good as hearing you actually explain why I got it wrong.
Matt, you aren't alone. The reviewers on the paper also said the same thing.
Oh, did they? They
did.
And you pushed back and
we rebutted them. Yes.
Yeah. I mean, it's I think it's a little bit difficult for the average person, which I would put myself in, to sort of wrap your head around the distinctions that were typically taught around study designs.
Yep.
When you are trying to relate a population level variable on a causal individual level basis. So, if I'm exposed to fewer people who are infected, does that, equate to less risk to me? It's not something that it's not looking at whether or not I'm circumcised specifically so much as whether or not the population is circumcised. Yeah. And I think that's just a little bit harder for people to wrap their their heads around.
No, it's definitely a challenging concept, and we were really careful to sort of explain what our rationale was, at least in the response to the reviewers. But yeah, I mean, even ourselves, when we were talking about this and what the study design was, we're like, yeah, no, it's a cohort study. It's definitely a cohort study. So I'm with you. I think it's challenging. Yeah.
Okay,
and maybe we could have laid that out better, I think, maybe in the manuscript. But
no, I mean, fair enough. I think we could always do a better job, but you do specifically say it's a cohort study, so I think that this one's on me. So the other issue that we were sort of chatting about over Twitter was, you said you think we put a little bit too much of an emphasis on this 0.1 number. So the 0.1 number that we talked about in the podcast was the idea that you're in the Rakai community, incidence dropped to 0.6 per 100 person years. Estimates suggest that we probably have to get it to 0.1 per 100 person years. I think I got that right. 0.1 per 100 person years to get HIV incidence to drop to the point where we could theoretically end transmission. And you said you thought we make a little too much of that 0.1 number. Can you say a little bit about why?
Yeah, I mean, I think it's a nice goal. It's something we can measure, but incidence is not the same as the reproductive number, right? So when we're
so can you explain what that is for the listener who doesn't?
So the reproductive number is the average number of individuals someone will infect in a completely susceptible population. That's the basic reproductive number. And then the effective reproductive number is the same quantity, but in a population with some where people have already been infected, or it's not a completely susceptible population anymore. And so when that number is above 1, we have an epidemic, and when it's below 1, we can control the epidemic, and the epidemic's on the decline, and we'll start to see a reduction in new cases. And so that quantity depends on a lot of different things. It depends on the underlying contact network. It depends on how long people are living. It depends on the individual level probability of transmission within couples. And so we've been able to reduce the probability of transmission with things like ART and with male circumcision. But I don't think we really know, I personally don't think we know what the reproductive number is right now. And I don't necessarily think the reproductive number of 1 correlates with 0.1 per 100 person year. So I think we need to do a little bit more modeling to tease that out a little bit better.
I think you're right about that. So I would sort of add to what you said there, that the intuition for why you want that number to be below 1 is that you can just sort of think of it as essentially replacement. That if everybody is on average infecting fewer than 1 person, then the number of new cases is less than the number of people who eventually would leave the population, either in the case of a treatable infection through cure or treatment or whatever it is, or through death if it's something that you end up with lifelong, like HIV, and therefore eventually you would be able to control the epidemic. And I think you're right. I mean, I think the modeling on this is still questionable. I think we really don't. In addition to what you said, which is I think we don't know what the reproductive number is exactly, I think we also don't really understand as well as we need to the dynamics of transmission, by which I mean how much of that, let's say the reproductive number is 5. Let's say on average, the person who comes into a completely susceptible population is passing on the infection to 5 new people. Well, how many of those 5 new people are happening during the period right after infection, and how many of that is happening over the decades that person is going to live? If much of that infection is occurring, before the person ever knows they're infected, it's very hard to prevent those new infections through things like treatment and pre-exposure prophylaxis. Well, I suppose that ignore the second one, but the first one, because you just don't, you're not on treatment during the time when you're passing on the infection. So I agree with you that I think we're not clear yet on what the actual number is that we need to get to.
I also don't think we really understand a lot about the contact structure itself. So we don't know, how, the ways in which people form partnerships can have a huge impact on the reproductive number. And we don't really have any idea of what that underlying network structure is.
Yeah, I would agree with you there.
Yeah.
Yeah, absolutely.
Yeah. So yeah, I agree. That acute early infection point that you just brought up is a huge debate
It is.
within the field, and hopefully there'll be some more research on that moving forward. But yeah, I wonder if that's why, despite scaling up and achieving 90/90, why we haven't really reached, we haven't really been able to reduce infection much below this 40%.
I suspect it's certainly a part of it.
Yeah.
Okay, so the other thing I wanted to ask you about was you commented on, and I think if I remember correctly, you said you agreed that that the out-migration from the Rakai population is an issue in terms of trying to draw inferences from the data that you're working with. Can you say a little bit more about how much migration there is in the Rakai population and what the challenges are there?
Yeah, so I just want to start by saying that Rakai is an open cohort. So people can leave the study and they can enter the study. So we actually capture migrants coming into our communities. But there are people who are leaving. And we see about 25% of our study population turning over between surveys, which is huge. We have some studies that are under review describing this phenomena in a lot more detail. But yeah, people are moving all the time, and this mobility is a huge issue. It makes it more challenging to interpret things, I think, but because we are capturing migrants in our study population, I feel somewhat confident we're capturing some of that elevated risk that I believe is associated with mobility. So I will tell your listeners to stay tuned because we do have a study coming out in Lancet HIV in the near future that's describing what's happening with migrants coming into our study population. But yeah, I think the people who don't participate in studies, we always have to make that assumption that they're the same as the ones who do. And, that always keeps me up at night and makes me nervous. So,
absolutely.
Yeah.
And I think, looking at the migration data in your paper, I think it's worth making 2 points. One is I think it's fair when you see out migration and in migration like that to have a little bit of skepticism. On the other hand, it is also worth noting that these are the realities of working on population level field sites like this. People do move, and we have to deal with it. And these numbers are not in any way inconsistent with what you would expect. And so I think it's fair to have a little bit of concern when you see it. But I also think it is the best that we can do. We can't force people to stay where they are, and we can't trace people when they move necessarily. And
I hope so.
I think it's just the realities of what we do, or what you do. I don't do this.
In my dreams, somebody gives me millions of dollars to go track down some of these people and see what happens to them. But NIH, if you're listening, no, I'm kidding.
I'm sure they are, and I'm sure they're writing up a notice of award for you right now.
Yeah, maybe. I think this is a huge challenge with these types of large studies, and I think the same will go with some of the randomized controlled trials that are going on looking at these same things.
Agreed. Yep.
Yeah.
And so the last thing I want to ask you about is something that you started with. So you have this behavioral data that you also looked at, and you said really not a lot of change over time, except in one indicator, which is delay in sexual debut. And I have 2 questions really. The first is why? Why can we not, make any real major dents in terms of behavior change? And then the second question is, how much should we believe the change in delay in sexual debut, given that people presumably know what the right answer is, or as these messages have come in over time? How much should we be a little skeptical of that. And I preface this with, it doesn't change the interpretation of your study because your study is focused on these other two factors. But I'm just curious your take on that.
So I'm pretty confident in the delay in sexual debut question, and I'm confident because I think we saw one case in that group over the entire like 17-year period.
Meaning one new infection among people who
HIV
said,
infection, yeah.
Among people who said that they had not yet had sex.
Exactly.
Oh.
So it's very, very low. So that's one way you could assess. You could assess whether or not that's an accurate measure.
Agreed. Yeah.
I think that's in the supplement. There's lots of stuff in the supplement.
I did read the supplement, but some of the supplement goes in one ear and out the other.
You're probably the only person that read the supplement.
I would like to say my two co-hosts did, but I can't vouch for them.
Everybody, I should tell your listeners to always check out the supplements because there's great information and supplemental materials.
But back to this question. So why? And I know obviously this is not your study's question, but I'm just curious if you have thoughts on why it has been such a struggle to implement successful behavior change interventions.
I have no idea. Yeah. It's just, people just do not want to use condoms. I don't know what it is. Maybe they're not comfortable. I don't know. Do we see huge... I don't know how much that differs in the United States.
I don't think it differs.
Yeah.
No, I don't think it differs much. I think this is the struggle. And this is, I think this is part of why male circumcision, HIV treatment, pre-exposure prophylaxis, all of these biomedical prevention methods are so important is because, there is a... behavior change would be great. Condoms are effective, but it has been so hard to get people to change their behavior. And I think we have to accept that is something about human nature. And we have to look for other ways.
Yeah. I think we should still, there are still people who use them. And if you do look at the effects among those who are using them, it is somewhat effective. So I think, we can continue to provide them, but whether or not we want to dump all our money into some of these campaigns, I'm not totally sure. Martina Morris has done some really nice work showing that you don't have to change behaviors that much to make a huge difference on epidemic dynamics. So that's also something to keep in mind. So maybe if we can only get if we can get 10% or 12% more people to use condoms or to reduce their number of sexual partners, we could potentially have large impact on the epidemic. So I would urge you to check out some of her stuff. It's compelling. But yeah, it's just been a struggle for years to get people to change behavior.
Yep. It just seems a nearly intractable problem. Maybe it's not, but that is my skepticism.
Yeah, mine too.
Okay, so I want to get to one last issue specifically about the paper, and it is the issue that I noted about the language in your paper, which is that I made the comment that you used the word probably, I think 13 times.
13 times?
What did I say? Or maybe it was 11, 12, somewhere in that neighborhood. And it was more than, I went back and looked, more than all the times it had been used in all of the papers we had previously reviewed. And I brought this up on the podcast, and when I went back and listened, I didn't emphasize enough that my reason for bringing this up is I thought this was a strength of your study, which is that I think that we as researchers are often either too enamored with our own results, or we just feel like we're supposed to approach our own results to put a lot of belief in our own results because others may be critical, or we believe it's not going to get accepted in a journal if we are expressing some I don't know what the word is, but that we are not 100% sure that we know exactly what's going on, but this is what we believe and this is the best evidence. So to me, I thought this was a real strength of your study that you were willing to say, we don't know exactly what's going on here, but here's what we think. Don't take this as as fact. And much of this was around your interpretation of the data, not around the actual effects itself. But I think this is something that we should be doing. And I wanted to get your take when you read other people's work and you see, you get to the limitations section and it's sort of a list of things that we think maybe didn't go quite right, but we can explain to you why you shouldn't really care about those things anyway. Do you have more or less confidence after reading those things?
After the limitations paragraph?
Yeah, I'll let me just say that I often have less confidence after reading the limitations because I often feel like, there are things that are pretty obvious that aren't in there. And I wonder, why didn't we talk about those things? Why are we trying so hard to explain it all away as opposed to just saying these are when we do observational epidemiology or even trials, there are limitations and we should, I think, embrace them, not run away from them.
You think there should be more of a discussion? Yeah, I agree. I feel like it's sort of this afterthought at the end of the paper, when really I think it should help inform the discussion a little bit more holistically, right? And I think thinking about the limitations is kind of like the best part of reviewing papers, right?
Absolutely.
Or like thinking about like what you're going to do next or how you can improve this or where we should be focusing our energies moving forward. And for instance, like the mobility issue, people will always put that as like an afterthought limitation. Yeah, there's a lot of mobility, but like I'm obsessed with mobility now. Like I feel like I have to know everything about it and what's happening and how it might be impacting interventions and stuff. And I think to some extent, like how much we can sort of pontificate about our results is limited by the journal. Like we don't have a ton of space to write what we always want to, but I do think in general we can be a little bit more humble about our results and feel free to discuss the limitations a little bit more without necessarily. I wish we could do that more without the fear of rejection from some of these journals, but I think that's going to be a hard thing to overcome.
It's an interesting point because, as you say, I mean, there are space limitations, and we all who have gone through this process know the issue that you get to where you have a word limitation of say 3,500 words. You are at 3,499 when you submitted it. Then you get the comments back, and they say, "I want you to add this and this and this," and then the journal says you have to respond to all of these things, and you also have to stay within the word limit. It's a challenge. I think you could potentially make an argument that maybe it isn't actually the author's job to point out the limitations. It's the research communities, and the consumers of this to point out the limitations. But then if you're going to do that, then I think you need a formal process to actually make sure that every paper gets a thorough discussion of the limitations by somebody outside. So I don't know what the answer is, but I mean, I think.
Do you think there should be a comment section at the end of articles?
I don't know about that. I mean, based on my experiences, I'm reasonably new to Twitter. But my experiences with Twitter is that comment sections on things are places for people to say nasty things. And as Don calls it, the bicker sphere. I don't know that a comment section on a journal article would necessarily be the same, but it does seem to be comment sections in general aren't the place for really rigorous debate. I do wonder about the idea of what if, if peer review were an open process, as it is in a few journals, but not many, where the peer-reviewed comments were published alongside with the paper, and so people could actually read the critiques. I don't know.
I think that would be great. I mean, eLife does that. I found them very informative. So there are journals that are starting to do that. I think it's nice. And I would like to see more of that because then you can see how the paper evolved. I do think making the peer review process completely open could be, I mean, just from, I'm a younger scientist and I'm kind of just starting out. Especially if you were reviewing somebody's paper who was much more senior than you in the field, like I think that could be kind of daunting to put your opinion out there. So I don't know. maybe.
Okay, so for the listener who's not really familiar with this process, what the peer review process says, you submit your paper, it gets sent out to some experts in the field who are charged with critiquing your paper and advising the journal on whether or not it is accepted or rejected, or there are things that you need to address before it's ready for publication. And this process is typically, although journals do it differently, typically anonymized. So in some cases, the person doing the peer review doesn't know who wrote the article. That's sometimes happens, sometimes doesn't, but it is very common that the authors of the article they get the comments back from the peer review, but they don't know who they came from. But some journals now are asking you to put your name on your peer review. Have you reviewed for any journals where they require you to put your name on it?
Not where they require me to do it. I usually say no because I'm generally concerned about what the repercussions would be. Maybe I should start saying yes. Do you say yes, Matt?
I do say yes. I do say yes, but I hate saying yes. I say it because I feel like it's the right thing to do, but I am always I am concerned. I mean, as you say, I'm concerned about the potential repercussions. I'm concerned about the that somebody is going to misinterpret, partly probably because I haven't said it well, what it is that I'm trying to say, or the motives behind why I'm saying it. And I every time I click the box, I sleep a little bit less well that night, knowing that I just clicked that box. I think in general, though, I would say I'd like to see more experiments and creativity around the peer review process. I'd like to see people trying, journals trying new things around how we improve this process, because I think it is a flawed system. We know that, but I think, it could be made better. And I think we've got to try new ways to try and make it better. I don't have the answers as to what they are, but I think we can do better.
Yeah, maybe we need some RCTs for journal review.
It strikes me as absurd that we're not doing trials of things like this, because this is what we as a field argue is the gold standard for trying to figure out cause and effect. And if we're not actually willing to do it with approaches to peer review, then I think we're sending a big message. Now, it would be complicated because how do you measure whether or not it's working and what the benefits are? But I still think we could think about that. I should say I also never understood why we who teach epidemiology, as I do, and don't actually do any randomized trials of experimental teaching methods to, what are the best ways to teach our students. We profess that this is the way to figure out what works, and yet we don't actually use it in our teaching methods. So that one's always bugged me as well.
It's a lot of trial by error, I think.
Yeah, definitely is. And subjective opinions on when something works. But anyway, I'm a little off topic here. So anyway,
that's okay.
Back to you and your study. So I want to just end with a couple of things. So are you familiar with the I hate when people ask me about acronyms, but I'm going to give it to you anyway. The ANRS 12249 trial, which was the test and treat trial that was done in KwaZulu-Natal, South Africa.
I am.
Okay.
I am familiar with it.
Were you involved at all?
Nope. No.
Okay. So for the listeners, this was a trial of this concept of test and treat, which is a big thing in the HIV field right now, where we go out into communities and we try and test people as often as we can for HIV. And if they test positive, we try to put them onto treatment as quickly as we can, because, again, under this theory that if we get people onto treatment, we reduce their viral load, they become less and less likely to transmit the virus to others. And the models show that this will work if we can actually do it in practice. The trial didn't show really a benefit. And I'm curious, in light of your findings, if you have any insight as to why you think the test and treat study, where it was a proposed intervention, didn't have much of a benefit, whereas just sort of looking at what was going on in the population in Uganda seemed to really have a benefit.
Yeah, I wonder if it's more of an issue of study design. I mean, if you look at the ARNS study, the intervention and the control, they didn't differ in terms of coverage of ART. So comparing them becomes challenging if they have the same level of exposure, right? So I think that was the biggest. I mean, I think that's the biggest reason they didn't see anything. But also, I wonder just more broadly, with a lot of these models, the initial models that were done looking at the impact of test and treat. I think the most famous one is by Ruben Granage. It was published in the Lancet.
Yep.
I think it's the Lancet. Yeah, back in 2009.
Yep.
And that's a very simple model that assumed, that there wasn't any sort of differential uptake of treatment in the population, and everybody was at equal likelihood of going on to ART, and almost everybody eventually did. And we know that's not the case. Like, so for instance, in South Africa, just as in the same in Uganda, we see that men are less likely to be on care, and we have some other data suggesting that people with higher risk sexual behaviors are also less likely to get onto ART treatment and enrolled into these care programs. And so I think there were some initial assumptions, that may have impacted what we would have expected to see. But I think the biggest issue with that particular trial is that there was no differential coverage in ART between the treatment and control arm. I don't know if you would agree with that, but
I would. I think there's one other issue that I think is going on, but to that point specifically, I mean, I think that this is part of why you'll often hear on this podcast, Chris will often be critical of observational studies and seems to really love randomized trials. I love randomized trials too, but I think what the differences between your study and their study illustrate, or one of the things that it illustrates, is we really need observational data, because you can't look at the effects of these population interventions in trial format now in exactly the same way you could have 10 years ago, for exactly the reason you said, which is that people are now have access to treatment. We are now supposed to treat everybody who we come into contact with who has HIV, and therefore it would be unethical to not offer treatment to anybody who came forward. And so trying to understand the impacts of these interventions, you really need historical, longitudinal, observational data. And that's, I think, what your study shows that a trial at this point couldn't.
Yeah, I think, I'm a little worried about some of the results that are coming out, maybe, or that are supposed to be coming out in the next couple of years. I hope they find something. Because the danger, I think, is if they don't, I'm afraid that might be fodder for, folks to say, oh, yeah, these interventions aren't working, we shouldn't be investing money in them. But really, it's just sort of this study design issue. So that's my fear with some of this stuff.
I agree with you. I think the other issue in that study, of course, was their rates of linkage to care, which is something that we focus a lot on, is if you go into the community and you test somebody, you then got to get them to a health facility to get them on treatment.
Oh, yeah, they were poor.
And the rates of linkage were low. And this is something that we've been shouting about for years now, is that your models can show that incidence is going to drop if you get everyone onto treatment. But getting people onto treatment is not an easy thing to do. It's just not.
So are you a proponent of same-day initiation of treatment, Matt?
Very much.
Okay.
Very much. Yeah. It comes with some risks. It certainly is possible that if we put people onto treatment the day that they test positive, that really what we're going to do is shift loss to follow-up to after treatment initiation, which has some potential dangers around resistance. But I just think we did a trial of same-day initiation in South Africa that clearly showed benefits in terms of both initiation rates, which you'd expect, but also in terms of, I think it was 8-month viral suppression rates that show that getting people onto treatment faster has benefits in terms of just getting people suppressed. So yeah, I definitely am. How about you?
Yeah, I totally am. I think that the data from your studies and from others have been super promising. So we're trying to do some of that work in Rakai now, but it's difficult to implement sometimes when there aren't the funds available. So,
Yep, absolutely.
But yeah, I think we need to be moving in that direction for sure, and I think we are, and we'll get there. But yeah, I think it's a great thing.
Fantastic. Well, Kate, thank you so much for coming on the show and chatting with you. I really enjoyed it.
Thanks for having me. I think your podcast is great. It's where we can discuss the limitations of all of our papers. This is
I hope so.
One forum.
I hope so. Thank you so much. So I just wanted to remind the listeners that if you got any feedback on this or any of our other episodes, or you want to suggest a topic for us to talk about, you can tweet us at @PopHealthyX. That's @PopHealthyX, or you can tweet me at @ProfMattFox. Or you can find us on the Population Health Exchange website at www.pophealthyx.org. As always, I want to thank Leslie Talalian, Director of Lifelong Learning at the BU School of Public Health, for supporting the podcast, and Nick Guler for sound and editing. Thanks for joining us for this very special episode of Free Associations and our first ever guest on the podcast. And if you think we should do more of these, tweet to us and let us know.